You're listening to the Doc Lounge podcast. This is a place for candid conversations with healthcare industry's top physicians, executives, and thought leaders. This podcast is made possible by Pacific Companies, your trusted advisor in physician recruitment. I am your host, Summer Gilbert, and I am the Director of Marketing and Branding here at Pacific Companies. And today, my co-host is Director of Recruitment, Mr. Casey Galpin. Thank you, Casey, for joining me today.
No problem, Summer. I'm happy to be here.
Today on the podcast, we're talking to Dr. Graham Wagner, board-certified physiatrist, working out of one of my favorite places, beautiful Utah. Dr. Wagner holds a specialty board certification in physical medicine and rehabilitation and a subspecialty board certification in pain medicine. Currently, Dr. Wagner is working in the Department of Neurosurgery. He works really closely with neurosurgeons, treating and focusing on spinal and musculoskeletal conditions. So we are really excited to have Dr. Wagner on the podcast and get to know more about his specialty in PM&R and more about his journey. So thank you so much, Dr. Wagner, for being here. I know your time is precious, so let's get started. And just a quick reminder, this podcast is intended to be an open forum. Any personal beliefs, views, or opinions represented in this episode are that of our guest and do not necessarily reflect the opinions of Pacific Companies. So please have an open mind and remember that this podcast is not a news source, but rather a safe and neutral platform for candid conversations. Well, thank you for joining us today, Dr. Wagner. Where are you out of again?
I'm in Salt Lake City, Utah.
Nice. I love Utah. How's the weather? Is it snowing today?
Oh, yes, very much so. We're expecting a couple feet over these next couple days, so I'm pretty excited. The resort's just opened up.
Oh, man, I'm jealous. Wish I was out there. To start, I'm going to throw this over to Casey for the first question.
Yeah, Dr. Wagner, what we like to do in the beginning of the podcast is just, if you want to just give us a quick 30-second, a minute kind of background about you, where you grew up, where you did your undergrad, medical school, kind of how you got your start.
Okay. I was born in New York, grew up there, upstate New York, and Massachusetts, coastal Massachusetts. Ended up going to undergraduate at the University of Rhode Island. And then a couple years after that, after I'd worked a few years in a job I didn't end up loving in the medical sales field, I moved out to Utah to check out the skiing just for a season. And like most people that end up out here, I couldn't just stay for a season. And so I ended up coming back for the next ski season, and then that was it. They had me. And just ended up loving the lifestyle, and ended up going to medical school 10 years after I graduated from undergraduate.
Yeah, that's a pretty rare to see somebody take a decade off, do a different career, then jump back into medicine. How did that affect you getting into medical school? And likewise, how did that affect you once you were in there? Did you find it easier because you had real life experience?
There were pluses and minuses to it for sure. I think that actually getting into medical school was probably a little easier. I did have some contacts, and I think medical schools realize that now, that doing other things and not just working from the time you're in high school towards that goal of going to medical school is somewhat of an advantage potentially. As far as going into medical school and it being easier or more difficult, I would just say that there were some things that were certainly easier. I had a work ethic like I didn't have even in college. I'd been working for myself for a number of years. And so going back and doing the work, I treated it like it was a job, and it was easy for me. Whereas other people struggled to be able to buckle down. Not everyone for sure, but some. The difficult part was going from being in control of my own life and being able to manage my time as I saw fit. I actually had my own business, and so um, going to be on everyone else's schedule all the time was definitely challenging. And I found that being stuck in a room for 70 hours a week in front of a computer or in front of a PowerPoint lecture was definitely a little bit difficult.
What inspired you to go into medicine?
So I had my stepfather, who I really respected, was a physician. He was a rheumatologist, loved his job, loved his patients, and really it was a career for him. It was, life defining. And I was always very impressed with that. I didn't go into medicine initially right out of college because there were so many other things that I was interested in. And I just didn't feel like I could make that commitment to doing one thing for the rest of my life. And I know there are exceptions to that, but for a large portion of your life, and at the very least the next decade, you are committed to medicine. And I wanted to know with 100% certainty, not only that that was what I wanted to do, but also that I didn't want to do something else more. So I tried a few things that were very interesting to me. I went to the State Department to work, and because I was a political science major coming out of college, I thought I might want to work in the Foreign Service and realized that probably wasn't for me. I worked in medical sales, and I also worked in real estate and construction. And so all of those things seemed like they were very viable career paths for me. But in the end, medicine still was more interesting. And so I'm very happy that I took this path, even though it was a little circuitous.
Hi, Doc. So taking back, so you're finishing up your medical school, what, third or fourth year, and you have a lot of different directions you can go. You can go to internal medicine, you can go family medicine. You have a lot of options, and you choose physiatry. How do you come about making that decision? What was it about physiatry that said this is what I want to do?
Right, that's a great question. First of all, the physiatry is not something that a lot of medical students even have exposure to. So I felt like I was lucky to even know about the field. It's certainly not a core rotation at every school. It wasn't at mine. And so I had heard about it from just, I guess, personal experience. Like most young males, at the very least, my primary care was orthopedics and sports medicine. And that was the only doctors I ever saw, unless it was an emergency department physician. And so I had seen kind of what they do to a certain extent. And so I knew at least that I wanted to explore it. And then once I had done a rotation, it was early in fourth year, and I had done all my big rotations prior to that, and so I had kind of seen what the vibe was of every specialty, if you can generalize like that. And I just thought that when I was around the physiatrists, like, these are my people. They're relaxed, they're caring, they're a very outdoorsy and sporty group. And I just felt like I was at home. Like, finally, this is what I'd been waiting for, that aha moment. And I was completely confirmed when I went to internship. There were a couple of preliminary physiatrists like myself, and like, they were the people I got along great with. And so it's sort of held true throughout that. Once I found, like, these are my people, I was very happy.
So, Doc, do you take into consideration, knowing some of the physiatrists there down the road, what the work-life balance is going to be? Because if you're on an orthopod, the work-life balance is usually not great. Whereas physiatry, most people consider that to be able to give you the opportunity to have one of the best work-life balances of any specialty in medicine. Do you think about that while you're going through this decision?
That was a big part of it. Um, I had looked at it in two ways. Like, okay, what can I tolerate as far as work hours? If I was going to go into neurosurgery, that's minimum 80 hours a week for 7 years at a minimum. And I
Hmm.
didn't think that that was um, going to be okay for my family and myself. But excuse me, I should say, internship and residency. Um, you work a lot of hours, and I would think all specialties. I did a lot of overnights. I did a lot of call. Um, and that was just sort of it's to be tolerated throughout training. After residency, though, I was definitely looking forward to a more office-based clinical experience, where I was had predictable hours and was able to kind of create my own schedule. So sort of my ideas for how I wanted my life to be after have really held true to a large extent. I should say after training have held true during my first year of in the attending world.
You did a chief residency year, correct?
I did, yes, I did it during my third year instead of fourth year, um, and it was quite enjoyable.
So, what made you decide to do the chief residency year? And is a lot of our podcast goes out to people in medical school or in early part of residency. How do you decide I'm going to do the chief medical year, and what all consisted of that year?
Well, for us, and I think this is different for different specialties, like internal medicine does a fourth year as their chief year. For us, it was integrated. That was an additional responsibility. We didn't get paid. It was just, something that we did. And I sort of chose that to do that. We had to be elected, of course, but I wanted to do it because there were some things that I thought I could affect, some change that I thought would be helpful, and I wanted a little bit of leadership and administrative experience in medicine. Just seeing if I liked that role, if that was something that I wanted to go into later. It was definitely doing it as a third year. I felt was interesting because the fourth years, um, I was younger than them and they had more experience than me. So there were times that
Mhm.
heads were butting a little bit, but overall it was just a great experience, and I would definitely recommend it to anyone that thinks they might be interested. Um, you know, when, Up front, it was very time consuming, creating schedules, things of that nature. But once the year got rolling, it was quite rewarding, and I'm definitely glad I did it.
You know what's interesting is we just recently had an anesthesiologist on the podcast and was told that anesthesiologists are the best for pain management. So, what are your thoughts about that?
I think it depends on the individual. I definitely think it depends on the individual because we all bring different strengths and weaknesses to the specialty. Pain management can be entered through a number of different fields. I think neurosurgeons have a part in that, anesthesiologists. I've seen radiologists um, apply, and I know at least one radiologist has done pain management, even though they have the alternate pathway of interventional radiology. Neurologists have that potential pathway, and so I think everyone brings something to the table. Certainly, coming out of residency, physiatrists and neurologists have a huge leg up on diagnosing pain generators. That's not really something, and seeing patients in clinic is not something that anesthesiologists focus on during their residency. That said, the interventional skills, by and large, I think anesthesiologists will have a leg up there. So entering the fellowship year, we have pretty divergent skill sets, but over the year, everything's, in my experience, anyway, they everyone's skill sets tended to converge, and we all worked hard at what our initial deficits were. So I think it much more so relates to the individual than to the specialty that they initially trained in. Because really, the fact of the matter is you learn whatever it is you need to learn, either through, seeking that training out on your own, or during the fellowship year. The pharmacology that the anesthesiologists are strong in, we're going to pick that up. The clinical skills, the physical exam that the physiatrists are strong in, the anesthesiologists are going to pick up on that. So I think for me personally, as far as who I would like to train with, I'd like to see somebody from every field in a fellowship class: physiatry, anesthesiology, neurology, radiology. I mean, those are all, all those specialties will bring something very different but very necessary to the training environment.
Yeah, it sounds like you guys all bring something to the table equally. If you had to go back in time and choose a different specialty, what would it be?
I've thought about that different times, and people have asked me about that. I initially went into medical school thinking that, well, I'm going to be an orthopedic surgeon, and because I had the most contact with orthopedic surgeons, it looked fun. It seemed a little like construction to me, which I was, involved in since I was a teenager. And then as things progressed, I realized that's probably not, being in the operating room for most of my clinical time just wasn't where I wanted to be. I wanted to be talking with patients. And so I think that if I had to do it again, and I could do this from physiatry, but if I were going to do a fellowship, I would probably do palliative care. I think that they just provide an invaluable service for people and their families in this really important time of their lives, and can really just change the whole experience of end of life care for people. And it's still, I'd be able to work with my interest, pain, in that capacity. But I have an awful lot of respect for those guys, and some of the palliative care physicians that I've worked with have been the best people that I've trained with.
It's crazy. I'm totally noticing a trend now when I ask this question, depending on the specialty the physician is. I'm finding similarities in answers. Like, for example, a couple ophthalmologists said ENT. We had emergency medicine physicians say general surgery. So I find that fascinating. But circling back to physiatry, what do you like least and most about your specialty?
So I think what I like most about my specialty, so now my subspecialty is spine care. And so I love my working environment. I work very closely with neurosurgeons over in their department, and feel that that's very collaborative, a very good synergy. We pass patients back and forth as appropriate, and I guess just that environment that I'm in makes me, love going to work every day. Another thing that I really like is like being able to diagnose a specific pain generator and address that for someone. And then being the physiatrist that I am, having them follow up and telling me all the things that meant in terms of their functional improvement, getting back to doing all the stuff that they really wanted to do. Somebody came in the other day and was like, I was able to walk around Seattle, and I haven't been able to walk around for more than a couple minutes in years. And they were on vacation with their family, and they were participants as opposed to just hearing about it. And it's things like that that make me so happy. So that's the stuff that I really like. So a harder part of the job is when someone comes in and maybe they, have putting up air quotes here, but a pain all over type situation. And maybe it's organic, maybe it's not, but really helping them navigate that. And oftentimes those are hard conversations if I'm not able to help them, because this isn't all the time, but sometimes when someone gets to me, they've seen a lot of different people in the past. And I really hate to pass people along again, because they feel like, okay, they're deep down the rabbit hole, and at some point, by the time they see me, oftentimes, and that this is the subspecialist. This is who should be helping me out. So that part of it's difficult.
So, are you doing a lot of or treating a lot of TBI or traumatic brain injury since you're working with the neurosurgeons?
So I don't know. I work in interventional spine just about exclusively. We have my department, the physical med and rehab department, does do follow-up care. We have an inpatient rehab unit here, and they will continue to follow up with the physiatrist, but I don't do that. When I trained, I certainly worked with a lot of traumatic brain injury patients, though, for sure. It was very rewarding seeing those patients get better and improve, and seeing the family kind of come to terms with what was going on, and kind of realizing what was happening, and how it's not the patient's fault, how they're acting oftentimes. It was just a really enjoyable part of my training, for sure.
So I've got an interesting question, especially dealing with the spine and the back. I'm sure you have a lot of patients that have chronic pain. And with the opioid crisis, I know doctors are trying to steer away from prescribing. What are your thoughts on that? I know doctors need to be really cognizant of this issue.
Yes, for sure. And in general, for acute pain, I'll prescribe opioids and other medications that are appropriate for short-term pain management. But by and large, I don't do any opioid prescribing. I think that now, the era that we're in, there has been, and especially over the last year to 2 years, there has been so much discussion in the media, and health departments are just advertising heavily. I don't know about where you guys are, but when I go down the main thoroughfare through Salt Lake City, down the population center in Utah, it's called the Wasatch Front, but I might see 5 to 10 billboards advertising either recovery from opiates, or some health department signs saying that opiates are addictive, opioids are equivalent to heroin, things like that. So I think people are very aware of that now, and most people don't want to go down that road. And I will hear more people ask for help transitioning to something other than opiates, rather than people ask. It's very rare for me to hear someone ask for opiates specifically. But there are plenty of things that are available instead of opiates for chronic pain. There's various neuromodulation devices like spinal cord stimulators, which are an implant that can be very effective for certain types of pain. Psychologic interventions such as cognitive behavioral therapy, mindfulness, treating underlying psychiatric conditions like PTSD, anxiety, depression. There are medications that can be effective in treating chronic pain. I don't know that there's any silver bullet or magic bullet out there for medication wise, but we do have a lot of different options for treating people. Pain is complex. It's not a one size fits all treatment algorithm, as much as we would like it to be. And so what works for one person doesn't necessarily work for another. So oftentimes, retrialing physical therapy and getting people to be more aware of their bodies, to be more aware of their nutrition, their movement patterns, is very helpful. And people might have pain for, 30, 50 years, I'll hear people say. And I never look at it like it's a lost cause by any means.
Yeah. Well, I'm curious to get your take on this big trend of CBD and cannabis pharmacies popping up everywhere.
Yeah, so that's interesting. We don't have a lot of good evidence that there is, a correct dose or a correct mixture of CBD and THC to treat pain. Some people try it on their own. In general, I'll tell people, and it's not legal here, and so it definitely varies state by state. Um, and different states have very different rules. Even if, like, for instance, in Vermont and New Hampshire, the rules were completely different, even if the intent of the legislature was very similar. How those rules were created and executed were drastically different. So for us, I'm able to tell people they have access to CBD oil. Um, it's worth a try. I can't tell them exactly how much to take or what way in which to take it, just because we don't have good high quality studies telling us these sort of things like we have for other medications or interventions. Um, and then as far as THC goes, I generally tell people, um, there are carcinogens in the cannabis plant. Probably don't smoke it. Um, and then if you are going to obtain cannabis that has some component of THC in it, then you probably want to start off with something that has a higher ratio of CBD to THC, just to see how you react to that.
Yeah. I've wanted to get a physician's take on this and see if there is actual research being done.
I think there may be a role for the cannabinoid receptors in affecting those in one way or another. In chronic pain, there are dozens of chemicals and receptors that are um, involved in the pain pathway, and so if we can figure out a place for that compound, those compounds, or that substance, or if we're able to create a synthetic compound that affects the cannabinoid receptors, we very well may be able to add that to our armamentarium for treating pain.
Yeah, I mean, if it works and there's less chance of addiction and it's actually taking pain away from people, I mean, that's what's important. But moving on to my favorite question, what has been your most unusual or interesting case that you've had so far in your career? I know it's probably hard just to pick one.
I've had quite a few that are extremely memorable, but I think that just because of the person and his unique situation, and it was something that I didn't see. This was during residency. A gentleman, I was working on the inpatient rehab floor. A gentleman, he was in his 80s, and he was a good, hardworking farmer, clean living. Um, but he had just tremendous atherosclerotic disease. Um, his when on an X-ray you would see his digital arteries lit up from all the calcifications. So it was everywhere, and he came to us. It had initially presented with rest pain, which is pain from poor blood flow that's not relieved with rest. It's a claudication issue. And the pain was bad enough that he had a below knee amputation that had progressed to an above knee amputation. And he was a very poor surgical candidate for that reason. He had, I think it was primary sclerosing cholangitis, and had a number of other issues. He had chronic kidney disease, so he was never going to do well at healing after this procedure. And he ended up just kind of going downhill through there. He had a couple of infections. Oh, and another part of his background was that he was a farmer, and he went out, and this was 15 years prior to when he had presented. He went out to mow one more field, and he forgot his blanket that he used to put on top. He had a metal seat on his tractor that had bolt heads sticking up, and he'd cover them with the blanket. But he got a sacral ulcer that hadn't healed in 15 years, and so it was still an issue for him. And so the foregone conclusion was that he was never going to heal well from that amputation, and this was for pain. And one of the primary indications for spinal cord stimulator therapy in Europe is rest pain or angina pain. So this was someone that probably would have been identified were he in Europe is a better candidate for that than a surgery. And so I was heavily into research and or researching spinal cord stimulator therapy at the time, and so this was something that jumped out at me. But he ended up passing away from complications of this, just worsening overall health, and it stuck with me for a long time.
Wow, what an experience to be a part of a case like that. Thank you for sharing.
We're getting up close to our time stop here, so I wanted to take a half step back, and if you can kind of go back to when you were a resident, and now that you've finished, you've been in practice for a while, what do you wish you knew in residency that you know now that would have made life a little easier?
Oh gosh. The fact that there is a light at the end of the tunnel. I always sort of thought that it was there, but I didn't know if I could believe it. So just knowing that is very freeing. But I probably could have relaxed a little. I felt like it was my job to be perfect all the time and to do everything right and to always be there and always have the answers. And, I think that people would have understood if I had not been, perfect all the time, or I was trying to be. I can't say that I was by any means, but that would definitely have made it perhaps a little more enjoyable for me. And I think I've given myself the right to not feel like I need to be that way now that I'm past that phase. And so that's been really again freeing for me. But definitely to all the residents out there and medical students as well, you need to not be so hard on yourself all the time. I think the people that go into this field can tend to do that sometimes.
Yeah, I could see that happening.
After obviously you finish your fellowship, the next year you start bringing in quite a bit of money. Everybody as a physician does. Do they teach you anything about finances? Do they talk to you about that? Or how did you manage to manage that aspect after you start getting large checks from a residency or fellowship stipend? How did you manage that aspect?
I may not be the person to ask that question. My financial situation was very different than probably most people coming out of residency. I'd been in the workforce for 10 years, and so I had paid for my medical school. By the time I was done with medical school, I didn't have any debt. My wife had been running her own business for 10 years, which she continued to do during training. And so, she kept us pretty comfortable. And we had investments that we had planned on just sort of selling throughout the the training period to pay for everything and kind of maintain our lifestyle. And so we didn't really change anything in that respect. Um, we didn't hold anything back that we wanted, um, during the training period. And so nothing's really changed at all for me. I'm able to put a lot more into um, my retirement account, especially because I work for a state institution. And so I was very cognizant of, what my retirement planning options were when evaluating different jobs.
Gotcha. So last one for me, and I'll probably get this wrapped up, is what advice would you give to somebody in medical school or residency about choosing the specialty that they go into for the next 30 years?
I would just say, think about it long and hard, deliberate over that decision. You've really got to like what you're doing on a day in and day out basis. Um, I mean, truly, if that's a long time to be doing the same thing, or even if you're taking various roles in medicine, it's an awful long time. Um, so just make sure that at its worst, are you still enjoying to some degree what you're doing? Don't just think about the best days. Think about the hardest days. Are you gonna be able to kind of take those as they come for years and years? And also, just think about, are the people that you're going to be working with, are they I guess the type of people that you want to be around day in and day out? Do you get something from them? Do you get an energy from them, or is it exhausting, or to be in that environment? Because over time, it's going to wear on you, I think.
And doctors, they're not retiring at 50. They go hard and have long careers. Can you see yourself practicing, into your 70s, 80s?
Oh, sure, sure. It's difficult for me to say now what things are going to look like in the in healthcare in general, what the environment is going to be, even 5 years from now, no matter 35 years from now. But I like to keep busy, so I don't know that 65 is going to come and I'm going to be looking forward to retiring. I think it'll probably be a little later than that.
Well, Dr. Wagner, I cannot thank you enough for talking to Casey and I today. After listening to your story, I feel like you kind of did it right. I don't hear about many physicians going to medical school later in life like you did, but you were able to get more professional experience, life experience, and that is priceless. And then also not having that financial stress and burden preparing yourself for medical school just sets you up in a different mindset. You can focus on learning.
Yeah, it worked for me. There was a significant opportunity cost, though, as I was making either no money or in paying for medical school, or making very little money during residency. All those years would have been very productive for me otherwise. So to do it, if I would say that there's probably not a right or a wrong way to do it. It just depends on what you think is right for you. Now, I will say that I would not have given up my 20s for any vocation. I loved what I did. I was able to ski hard on 20-something-year-old knees, mountain bike hard on 20-something-year-old legs. So, I wouldn't change anything, but I just don't know that there's a single right or a wrong way for any individual.
Yeah. And I'm curious, so our listeners can get an accurate understanding of your journey. How old were you when you actually started medical school, if you don't mind me asking?
Oh, I guess I would have been 32.
Gotcha. Okay.
Yeah, no, it seemed like a good time. I still felt as young as I did when I was 22, and felt like I had a little bit more experience with just everything. Definitely a higher maturity level than I did at 22, and it was yeah, worked out right for me.
Awesome. Well, thanks again, Dr. Wagner. It was such a pleasure having you on the Doc Lounge podcast today. And we enjoyed you so much, we went 15 minutes over our normal time.
Well, thank you, Summer and Casey. I appreciate it.
Well, what does the rest of your day look like?
Oh, I have some administrative time, so I'm taking care of some paperwork, and I'm watching it hammer snow here. And so I'm just thinking about how much skiing I'm going to do tomorrow.
Sounds so fun. What ski resort do you go to?
Yeah, so I live in Park City. I think tomorrow we'll go to Park City, and then probably Friday or Saturday go up to Solitude.
Cool.
Check that out. There's a certain amount to, certain advantage to having these big amalgam passes where there's like 30 different ski resorts on the ski pass.
Sweet. Well, thanks again, and I hope you have a great day.
Awesome. Thank you guys so much. I appreciate the opportunity. I hope this was helpful. It was certainly fun for me.
It was great. Really insightful.
Well, happy holidays.
Happy holidays. Take care.
You too.
Bye.
Thank you to all our listeners. If you'd like to be notified when new episodes air, make sure to hit that subscribe button. And thank you to Pacific Companies. Without you guys, this podcast would not be possible. If you'd like to be a guest or for more information, go to www.pacificcompanies.com.